Ok, ya se está emitiendo. Incluyo si conecta a internet también. Pero no va a dejar nada. Por eso no puedo.
And here, the network and one here, we put the clip laser change it and
Está conectado, pero no.
put one more.
Unidad.
To take the button here once more, then it remains only, like you said, and more small coil. So this is
I'm not being about.
outcome version.
No lo habían capado.
Taking of the noise
Vamos
and
a ver a ver si tú.
controls. What I wanted to say, show you, also very difficult analysis can be done. Here is, it was Monday, so Monday, this is a middle-aged male, had 3 bleedings, ZA, left oculomotor, also. We decided to avoid operation. Then this is the operation. See, you go from the left side. Here is posterior direction for the open cervical. That's subtemporal approach. And spinal maybe to have a slight gray. Good neural anesthesia without good neural anesthesia without good teeth. We can.
Me parece que se ha vuelto para el
Surgery. Details.
Me parece que el quiz está separado. Me parece que el quiz está separado. Porque no le veo yo el contenido que sigue el segundo. La pasa igual que hicimos el otro día. Hay que parar la grabación porque otra vez. Mierda, coño, cargarme ella el link. Que más que no puede, ¿no? Que no puede, ¿no? Me he jugado. Me he separado. De hecho, está separado. El tiempo separado. El tiempo separado. Pero no, yo creo que más alto. Ahora más alto, sí. O sea que el tiempo más alto. Que si consigo yo que
Doing avian surgery, don't fight your husband, your wife, your boyfriend, anyone with administration before surgery. Surgery so that you, if you begin to travel off those customers, then you and you cannot try it. Take the patient, that's then you know the patient already realized because you have to know that this is really you have to have attitude like a winner artist depending on your cultural background to do avian surgery. But you have to be sure that you win the game. So this is number 3 in my series. 82 goal. Surgeon in the world. And so if you can embolize these ones, so this is good. So as been as had with Professor More. And what is our only tools in open microsurgery? So it is bipolar coagulation. We have to coagulate vessels. So we have to coagulate vessels for what was found the second be just bleeding because the do, and is coming.
made good recovery. But again, here, immediate operation after embolization saved his life. So we have been nowadays more reluctant with the AVM embolization. And I saw one case without any couple. This is parietal AVM. We operate the patient usually in sitting or semi-sitting position to have reduced venous flow, less bleeding. And here again, you see this is the hemosiderin after bleeding. You see it in the brain substance, and golden clips are temporary clips on the big feeders, which we find with ICG during the operation. So going around, and last vessel to be taken is the draining vein. And the most difficult AVMs are those which have only one draining vein. So if you hurt the draining vein, then you have big difficulties during surgery. I think I have used my time. Yeah, okay. I will then, if it is so interesting, so this encourages me very much. So Video Asthana, so here we see more difficult AVMs. I have to go here around. No more here. Here is good video. This is made by one Egyptian fellow. He is making the best videos in the world, is Jim Osman saying. It's coming soon. I want to show the beginning here. Here. Okay, this is the lesion. Large AVMs, how would you grade that? 3, 4? Special Martin. And one of the difficulties is here. One big draining vein, only one small draining vein. This is for the open microsurgery extremely important. And I think also for endovascular surgery, or how do you think, Serohan? Yeah, very important to take a look on the draining vein. So this is the patient is now prone, lying. So this is the backside. And Dr. El Sarkawi has made very nice video here showing the AVM. And then we make ICG to see the big feeders. So we put temporary clips on the big feeders. And this reduces the pressure in the AVM. And this has been one of the big steps as compared to 80s when we didn't use this method. And of course, preoperative embolization has changed a lot, but there are also many complications, and I think this depends on the skills. So you have to know the pathophysiology of the AVMs very well if you want to make onyx embolization very well. So you have to have a good touch, you have to know the anatomy, and this is water dissection. So we dissect with water between the brain and the AVM, and under high magnification. This is a very big draining vein here, red draining vein. And this is an artery. And we cut under high magnification carefully. Kamiyama scissors. I go around the world when I see a good instrument and I buy it. So this is what I call stealing the experience. So it is very good to go around in different departments. If you are training in only one place and stay there, then you lose a lot. So there are many ways that go to Rome, so you can learn many good tricks. And the more you have done, the more you have eye to see the tricks. So carefully going, there's a gliotic tissue around the AVM, and we coagulate. After embolization, there's many times infarction zone around, of course, easy for the patient, but obviously some part, take a look here, how nicely he's doing, how we are going around the AVM. What happened? No. So AVM surgery is going around. So if you begin to choke or flirt with the scrapness or doing something, so you lose the game, because then you have bleedings. And here, very big draining vein, we coagulate down and cut. And this is the thing then. And of course, then after surgery, control DSA always to see that the whole AVM is gone. And this is the AVM. And then careful hemostasis, and these are the postoperative controls. There is a suspicious state. This is the feeding vessels, and we controlled later, so they disappear usually. These are the big feeders, and these are the postoperative CT, and this is the part of the brain where the AVM was located. And then there's occipital AVM. This one I saw the last one, this is grade 5. Here, very big AVM is coming soon. This is a frontal AVM. This is rather regular AVM. I didn't want to show it, but it's beginning after this one. And as mentioned, you have to be completely sure that you have taken all the AVM out. So you touch everywhere the bed and then make a very good hemostasis. This was a frontal AVM, and now it's the large grade 5 occipital AVM is coming. This is certainly the last case. So I have used my time. Careful hemostasis with different hemostatica, tissue glue, and perfect hemostasis, and then very careful closing, moderate hypothermia after operation. So this was a frontal AVM, and now the regular AVM. Or there are no regular cases. So if you say this is a easy case, then everything might happen. So this is a very large occipital AVM, third one. And again, sitting position, young boy. And here we go around the AVM. There's a huge draining veins. And then we have to find the feeders and to put the temporary clips on the feeders. And this was very difficult in this case. Now we are coming. This is the occipital artery. I coagulate immediately. And this is the draining vein. One more. And now the AVM is coming out, and there's a rule that there is always one vessel left, so don't lift it immediately out because you may rupture. And usually with the draining vein, there are two arteries that feed the AVM. So this is important to know, at least in open microsurgery, so that you coagulate them. And if the AVM is filling, so you have to coagulate them around the AVM. And here I put exceptionally a clip in the AVM because the draining vein was so large. But otherwise, I'm not using any clips, just bipolar coagulation as mentioned. The part is, now we lift the AVM out. There's a big hole, and the AVM is around 7 centimeters. These are the postoperative controls. concluding words. So I think this is great Canadian microsurgeon said that we should analyze our complication. This is don't forget the complications, analyze the vertebral basilar aneurysm we wrote, and that remains in the historic book. This is important for endo and extravascular surgery to save future patients from fates. So what has changed? I came to neurosurgery 1973. What has changed? Better images, preoperative embolization, better microsurgery, high magnification, temporal eclipse, and intra and postoperative care are better. What has changed in the clinics? Beds less, intensive care beds 4 times more, nurses, neurosurgeons 2-3 times more, but administration 20 to 25 times more. So this has happened all over the world and wherever you go. So the number of people in administration is by far higher. So you have many times the feeling that you are working here and then around you there are many people asking different questions. Why did you spend so much money, so little money? Why did you do so little work, so too much work, and so on? And I touch only dural AV fistulas. We have large material. Dr. Anna Piippo made his PhD. I touch these completely quickly. I just saw 2 difficult cases we couldn't manage. And guess which one is endovascular and which one is surgical. Best hands have treated. There are dural AV fistulas which like flourish. When you take them some part out, then they give more and more. So there's some factor producing fistulas more and more. Thank you very much.
It was an excellent opportunity to listen again, Gallant in AV surgery. So thank you. Thanks to you.
Thank you very much.
Any question in the audience?
Yeah, please, microphone.
You showed very diffuse large frontal AVM, the grade 5 frontal AVM, very diffuse, and in our group of people, I always fight against that. There is a tendency to call these diseases a proliferative angiopathy. Oh, this is not an AVM, this is a proliferative angiopathy. Mm-hmm. So I always disagree with that. I mean, do you think that is there such a disease, first of all? And even there is, I think, according to my opinion, I'm going to first say, then I'll listen to your opinion. We should not overcall this as long as we see a draining vein in the arterial phase.
This had draining veins, and the patient had the psychoorganic syndrome. He deteriorated in his intellectual capacity. So I think this was symptomatic AVM. And the main thing was that we made a mistake in the angios. We didn't make 8-vessel angio. So this is very important.
So you believe that most of the, almost most of these that being called proliferative angiopathy is actually very diffuse cortical and subcortical AVMs?
I think so. Yes.
Thank you, Professor Herreniemi. One question. When I started to treat the AVM in Paris in 1918 with Pertuiset and Las Junias, I don't know I understand very well what is the morphological anatomy of the AVM. But the question for the surgeon is what is the arteria, what is the nidal, what is the vein, what is the flow. And then about 5 years ago, here in this hospital, he worked with Dr. Gomez and Dr. Rodriguez Boto, treated more than 30 patients every year, the big AVM, and I understand more the anatomy of the AVM. In the bigger AVM, you are the collateral hypertrophy, collateral circulation, and this is very good to treat it.
Yeah.
You don't worry that you are the problem. It's possible to embolize or surgery more aggressivity and less deficit. And the complete a new idea I treated in this center is to treat it and attack the AVM, the collateral, not the direct. I got with the collateral circulation, with the leptomeningeal anastomosis, so I start with the deep territories, and of the surgery is most easy. It's most easy. But this is a theoretical point. The problem is when you start to treat the AVM, caricature of the hypertrophy. You don't know very well what is the vein, artery. And in the bigger, final comment, in the bigger AVM, what do you think they treated step by step? No, in one set.
Then came. In this came. I both beginning of my series, I made 2-3 steps like it was recommended, but nowadays with the temporary eclipse and preoperative embolization and with different adjuncts, so I think it is better to do in one step, because if you leave some remnant, it might bleed, and I think at one time.
Sorry. Professor Ernest-Niemi, some teeny question. Do you have special tips or special different tips in posterior fossa AVM?
Posterior fossa AVMs?
Yes.
One important thing is that they are more dangerous than the other ones. And then usually posterior fossa is smaller than supratentorial rule. So they look like the surgery, and preoperative embolization is helpful, of course, because it gives some idea of the anatomy, but I think they should be treated because they are the most dangerous ones.
Professor, in order to improve the surgical remove related to the technique success after remove, when is the good time to stop the preoperative embolization in high-grade information?
In good time. This is
Depending of the malformation, depending of the surgery, depending of the endovascular surgery, depending of the flu, what is the good time to stop the preoperative embolization?
I understand this well, and I call it, you might get onyx drunk. So you try too fast, and then suddenly you know that there's slowing in the draining vein and then rupture. So you should stop before that. So better to do in several sessions, and little steps. So especially in large AVMs. Of course, smaller AVMs you can occlude totally with Onyx, but larger ones are dangerous. So like I showed you, so many intraoperative ruptures and even fatal ones.
Thank you. Good. Proper question. Do you have cases of brainstem AVM cases? Or surgical
Inside brainstem.
Yeah. Of
No,
course,
I have
yes.
not operated on inside brainstems. So I think they belong to the radiosurgery, and if they are parabrainstem, so
Only
around the
parasite.
brainstem,
Yeah,
then you can
only
take
parasite.
out, but not inside. Inside is not surgery. It is not
Okay, thank you.
in my skills.
Thank
inside
you.
my
Thank you
skills.
very much.
Thank you.
Now we can follow the order of the course.
So,
you want
thank you, everybody.
Do you want first? Do you want first or the same order? The next speech is from Ankara about a new proposal of classification of the aneurysm occlusion or not.
Thank you very much.
No, quedan estas tres y las de Luis, porque estas dos ya las he dado juntas una detrás de otra. Ya no, por eso, que este se tenía que ir y por eso hemos cambiado el orden. Quedan nuestras tres charlas y luego la de Luis. ¿Vale?
Let's move with the next round table. Now we're going to have a presentation by Professor Saracchi and Professor Slerik from Ankara. The name is Consecutive Follow-up Results of Aneurysm Remodeling After Web Treatment, a discussion on whether we need a new classification for aneurysm occlusion or not.
Let's do this first. First, I would like to thank Luis for his very kind invitation. It is always a pleasure to be in Madrid, Spain, and with you, my friends. Today, I'll talk on the follow-up results of after web treatment, and I would like to open up a discussion on whether we need a new classification for aneurysm occlusion or not. Modifying the flow from in and out of the cerebral aneurysm with different devices created a revolutionary paradigm shift in the endovascular treatment of aneurysms. With these techniques, treatment of aneurysm sacs happen in a period of time with a process we call flow remodeling, induced by the flow modifiers. And we started to learn this with the dedicated flow diverters after our experience with telescopic stenting, so-called homemade flow diverters. Flow remodeling process can be completed with perfect reconstruction as such in this example. Or this process can complete itself with near perfect reconstruction if there is a flow demand due to a vessel coming off from the sac, like in this one. So what are we going to call this? A remnant or just the remodeling of the aneurysm due to flow demand? If the flow demand of such vessel coming off the sac is not significant, this process is completed with progressive reconstructive deconstruction, leading to either vessel hypoplasia, like in this one, or in occlusion, like in this complex aneurysm treated with pipeline placement, ending up a complete occlusion of the aneurysm and the filling of the vessel, but in a retrograde fashion. So it is occluded, but with pile anastomosis, it's filling in a retrograde way. We understood that of such critical vessels coming off the sac plays a major role about how remodeling ends up. Question is, are those aneurysm remnants? Do we need to worry about them and retreat them? For example, in this one, a large PCOM aneurysm with the pipeline placement in 3 years' time, a very good remodeling. So what do we, how do we call this one? Do these have any significance, clinical significance? With the introduction of the intrasaccular flow modifiers, we learn about another form of flow remodeling induced from the inside of the aneurysm. The aneurysm, and it became the continuation of the vessel, and it's very stable. However, flow remodeling with web device rarely results in perfect reconstruction as well. Like in this one, for example, this ruptured aneurysm, it treated the aneurysm instantaneously and very, very effectively with complete, very nice reconstruction and nothing in the lumen to spare the neck. But mostly ends up with flow remodeling that we have been meticulously searching with if those are remnants to regrow, like for example in this one, a good placement as confirmed by the DynaCT, as we always do, very nice occlusion even in the 24-hour, 6 months control, remodeling, and there is some, you may say, enlargement of the neck. However, it is very stable. So at the moment, we are calling this a remodeling rather than a remnant after being sure that they are not growing. Of course, 1 year may not be good enough, so we will still get additional controls. This ACOM aneurysm, wide neck, web placed, a very stable remodeling at the neck. Another example, a complex large MC aneurysm, both branches coming off the sac, and the web ended up having a remodeling, very stable through 2 years' time. So is it clinically significant to have an remodeling such as this one? This lady has a subarachnoid hemorrhage from the right large MCA aneurysm. However, she has another one on the left with a nipple, and here it is. So we treated the right one with balloon-assisted coiling, but leaving the origin of the superior trunk open to not to compromise. And it ended up in 3-month control with recanalization, which we retreated using stent-assisted coiling. And for the left, in the same session with the acute treatment, we placed a VEP device on this side. And this is the 3-month control on this patient. And at 20 months, it is still stable with no change at all. Another example, very nice remodeling. And this is 6 months control. Look at the first year control. So are we going to call this a neck remnant, or is it just the remodeling of the bifurcation? Another example, like extrasaccular flow diverters, flow remodeling develops according to the flow demand of the vessel that was covered with VEP device, resulting in hypoplasia or long-term occlusion with progressive reconstructive deconstruction. For example, in this one, very wide with the superior trunk is open, and the inferior trunk got hypoplastic in the follow-up, and very stable remodeling of the bifurcation through 21 months. Another example, this time, this branch is filling through sort of a rete type small connections, thin connections, however patent. And in 1-year control MRA, looked like it is still patent. Of course, we are not sure, since it's an MRA, whether it's filling in a retrograde fashion and it is occluded. This case is very disputable, and we can talk on forever. This left MCA trifurcation aneurysm, very complex shape. A VEP device was placed because we thought any other treatment would be more risky. And this is at 3 months. Remodeling of the bifurcation, some neck remnant possibly. However, what are we going to call this filling portion? Is this a rem going to regrow? Near trunk is patent to controls, and after 1-year control, between 2 years control, it got occluded in an asymptomatic fashion, and the filling portion is not changing. So we are not sure what to do. We are still following, but we thought for this particular case, this is a good result if our treating the picture but the patient. So we are keeping the records of the Turkish patients in a Turkish VEP study registry, and targeted to obtain multiple consecutive angiographic studies, including 71 aneurysms. I'm going to concentrate on the follow-ups rather than the morbid mortality safety issues. We have at least 2 angiographies in 57 patients and 3 more patients with 1 control only. And so-called complete aneurysm occlusion, as described by Roy-Raymond classification, is only 12% in this group. The remaining we call in general remodeling. We don't know there will be regrowth in the future, so we do very strict follow-ups in those. For example, even this one, we did not call complete occlusion. This is supposed to be class 2 according to Roy-Raymond classification, but it's a very nice occlusion of the aneurysm and the remodeling of the origin of the artery, to our understanding at least, which is stable for 18 months. In the literature, there's a term, adequate occlusion, which is changing between 92 in the series, in the web series, which includes neck remnant and complete occlusion. In a way, suggesting the same findings. For example, this one, in our series, it is not complete occlusion. It is so-called adequate occlusion according to the literature. In our group, we call this remodeling. That's why our remodeling term includes more than 80%. Only this one you may call a complete occlusion. This is the only one with the remodeling ended up in regrowth. And I'll show this example and discuss that one. This lady has multiple aneurysms, and we treated the joint ICA with coiling plus pipeline and decided to treat the web device not by Y stenting, so that it will not hinder the treatment of the M1 aneurysm with flow diverter. And this is what we did in the same session. 2 aneurysms were treated, the left MCA with web device, very nice placement. And this is the control at 3 months. So there is remodeling of the aneurysm, and treated in that second session the M1 with pipeline device. And this is the 12-month control on this patient. And at 30-month control, 2.5 years, it is slightly changed, with rounded a little bit. So it's a regrowth. It is changing its shape in the follow-up. So we don't know if we are going to retreat this or not, still following, but it's a remnant according to our understanding. So overall, after showing all these examples, we believe that there needs to be a new aneurysm occlusion classification. Apart from the classical, conventional Roy-Raymond classification for aneurysm treatment result, there have been other classifications by Byrne, by Grunwald, by Chapeau, and some only focused on extrasaccular flow diversion, some but not covering the entire group of aneurysms. So this is our proposed classification, expanded from the Roy-Raymond classification. The class 1 is complete occlusion, yes, but 1A, 1B, 1C for the extrasaccular flow diverter cases, if there's a vessel coming off, whether the vessel is patent or not. And additionally, we have class 4 for immediate post-operative result for the flow modifiers diverters, 4A with stagnation, 4B without stagnation, if there's an aneurysm filling at the immediate post-operative angio, and a class 5 stable remodeling modification. We demonstrated with at least no change. Here it became hypoplastic, so it's a 1B. And here it got occluded, therefore it is 1C. And in this example, the flow diverter, the right superior cerebellar aneurysm is class 1A with the patent branch completely occluded. The left superior cerebellar artery aneurysm shows remodeling, which is class 5. This one, Webb plus flow diverter. Why is that so? Because there are two aneurysms, and the M1 aneurysm is a class 1A, and the Webb plus pipeline treated right MCA is a class 5, because there's remodeling at the bifurcation. This is an interesting case. 3 months, 6 months, and 12 months look like it is remodeling and no change at all. So, and it is why? Because there are branches coming off, so that's why the remodeling occurs. And according to Raimon, it's class 2 because there is supposed to be a neck remnant, at least it looks like so. However, in the proposed classification, it's a class 5. And for this ACOM, ruptured ACOM, class 4A at the end of the placement, and 3 months control, it can be reported as class 2, a neck remnant, because we don't know if it's going to regrow or not. But after seeing that it is stable, it can up this classification to discussion. And I thank you for your attention. And also I would like to invite you all to the live case conference in Chicago this year in June. Thank you for your attention.
Discusión. Discusión al final. Okay, so we'll have the discussion afterwards. So we move on to the next presentation. It's will be Dr. Henkes from Stuttgart, a novel intranumerosmatic flow diversion concept.
Should we save time with the discussion of this nice presentation? Okay. You don't want to save time with the discussion? This previous.
Yes, we will have the discussion at the end of the presentations. Final. Well, we take advantage of the if there's even one question, Alberto.
Now you the basic response of the MCA aneurysms with inferior branch. Why do you think this branch get up?
Since there's not much of flow demand through that time, it gets smaller and smaller. No flow demand, it may even get occluded. That's the experience, diverse, and also with the intrasaccular ones. So, of course, that branch may even 1 year as well in an asymptomatic fashion with lateral.
Yes, but I understand if you put a flow diverter, okay, in the superior trunk, I understand why the inferior trunk gets hypoplastic. But why with an intracircular device?
It is taking the origin of it, so it works in the same way. It hinders flow through the percent, like flow diverters, not occluding totally and abruptly, reducing the flow through that branch. So with the reduction in the flow, in the period of time, the branch gets smaller and smaller if there is not much of flow demand through that vessel. If there is a strong flow demand, then it may even stay at the same size, despite that the flow is reduced, or not the flow, the origin is compromised, let me put it that way, even though the origin is compromised.
Okay, thank you very much.
Absolutely, absolutely. Otherwise, you will get thrombosis of that vessel abruptly, immediately. That may cause clinical problems.
Thank you. So we have the next presentation, please, Professor Henkes.
Yeah, ladies and gentlemen, I think the first issue I have to address is that what I present you here is not really a flow diverter. Conceptually, and I think you will understand this in a second, it's a graft. The function is more a graft than a flow diverter. So starting with the Professor Moray mentioned PCONUS. PCONUS is a stent, a mechanical device which is made to keep coils. Is it so bright like here? To keep coils inside a bifurcation aneurysm. And starting with this construct, you see here the device has a shaft here and has this little pedals or crown. They are implanted into the aneurysm. The shaft is fixating the device into the parent artery. And as soon as this is in place, the device can be used to coil the aneurysm, and the coils will be kept in place by the device. PCONUS is available with diameters of the vessels between 15 millimeters and down to 4 millimeters for small bifurcation aneurysms. And this is the structure. If you start with this point, if you consider to cover the pedals with a polymer membrane, you end up with a device which is called P-Canvas. P-Canvas is made for the treatment of bifurcation aneurysms, and it combines both. It combines the mechanical effect of PCONUS and adds a hemodynamic effect, which is related to the membrane connecting the pedals on the distal end. It looks like this. This is this is a profile of the pedals, and the pedals are connected with this membrane. And the membrane is very thin. It is thin, has features like skin, so you can penetrate the membrane with a regular wire and a regular microcatheter. And as soon as you pull it back, it will more or less completely close afterwards. So if this is pulled back, this hole will close by itself. A different structure, P-Canvas umbrella. The regular shape is a connection of the pedals, as I mentioned, and this is more the connections between an umbrella-shaped metallic structure. The advantage of this is, the expected advantage of this is that this umbrella shape would seal better the neck region of the aneurysm. Just a few cases. This was a basilar tip aneurysm, which was had ruptured and was coiled in November 2012. This is the result of it was done elsewhere. The result of the coiling and the first follow-up from November 2012 to July 2014, with a major recurrence due to the migration of the coils into the thrombus. This is the recurrence. It was treated at this stage. It was treated with P-Canvas. This is 16th of July last year. It's an 8mm implant, no coils. That's 2 days later. The flow inside the aneurysm is instantaneously interrupted, and the sac is thrombosing. This is July, this is August, 4 weeks later. There is, of course, a significant neck remnant, and the advantage of this is that you could either coil it, or the structure at the neck is like a P-conus. You can go there and coil the rest of the neck, or you can put a flow diverter on either side. That's the thrombosing aneurysm. This was a not so difficult aneurysm and a very difficult lady. She's a nurse, and she came and said, yeah, I know I have this aneurysm. I can tell you what I don't want. Don't want surgery, no coils, please. I don't want to have a stent, and I would like to have glue. I managed to strange enough. So I managed to convince her that glue is maybe only the second best option, and we agreed that the P-canvas could be a good choice. That's immediately after the P-canvas implantation. I think it's slightly better than gluing the aneurysm, and that's a follow-up 3 days and 6 months later. The aneurysm, the sac is occluded, and there's this neck remnant, and now she comes again with the glue thing, the thrombosed aneurysm. Another case, even more difficult, coiled in Nancy in 2000. I was in Stuttgart. This was the first result. This was done after subarachnoid hemorrhage in March 2006. This is 2010. She came back and had a recurrent hemorrhage. We recoiled the aneurysm with crossing solitaires, the left prior to treatment, right after treatment, crossing solitaires and coils. In 2010, she recovered quite good. The third, again, recurrence in 2011, again coiling through the crossing solitaires. 2012, the next recurrence, again coiled through the crossing solitaires. Coil treatment number 5 in 2013, catheterizing the aneurysm, filling it through these crossing solitaires. This was March 2014, coil occlusion number 6. And this was the last recurrence in October 2014. This is P-canvas, and we went through the P-canvas. I hope we can start it. No. If I would be able to start it, you would see that the catheter easily penetrates the membrane and allows coil occlusion of the remnant. With this result, she was at follow-up last week, and the aneurysm is still completely occluded. But okay, there's a significant rise if certain requirements are fulfilled. The most important requirement for this device to work is that you should not have any offset of the axis of the parent artery and the aneurysm. The aneurysm longitudinal axis and the longitudinal axis of the parent vessel should be more or less in line. The more angle you observe, the less function you can expect from this device, because it's inherently stiff. It won't kink, it won't bend. It only works, and in this version, it only works in a straight fashion. So it's obviously suitable for wide neck bifurcation aneurysms. It apparently combines the mechanical feature of P-conus and hemodynamic function of a flow diverter, or as a graft. I think the membrane deserves the word a graft. Can be used with coils or alone. You can easily catheterize it, and you can come later. We did animal experience. You can come after 6 months, catheterize the membrane and put coils inside. And the next design variation will be an articulation between the shaft and the crown. Thank you very much. I made it short in order to allow you had to show more surgical movies.
You have a question for this presentation?
Very short question. What is your experience with PCAMs without the coil, only with the device?
We did a couple of cases in Stuttgart, and we did a couple of cases in Buenos Aires. I personally think you can go for a treatment without coils in case you instantaneously see significant stasis of contrast in the aneurysm. If you see washout of the aneurysm, I think there is no point to leave the aneurysm as it is. It's much better if you deploy the device. You can withdraw the device, so you can try different positions. But if you see continued flow, I would rather go for coiling than for waiting for a miracle.
Another question? No, thank you. The next presentation is the initial experience with a Pulse Rider device presented by Professor Francis Turgeon. Where is? No? ¿Para? Okay. Okay, finish the session. Or you come back at... Okay.
Well, there is a room for discussion now. I have one question to the previous speakers, which is you have shown a very wonderful ways to treat very difficult aneurysms, but we are really interested in the outcome in terms of a neurologic outcome and also in the rate of rebleeding. So, which is the you said you have a 6% of ischemic complications and 3% of more severe morbidity or mortality, and you have also proposed a classification, but I have not clear which is the relationship of the classification with the rebleeding after the stenting, because I think the main criteria to define whether an aneurysm is occluded or not is the risk of rebleeding.
We don't have any case of rebleeding or bleeding in this series treated with web device among these 71 aneurysms, 68 patients. So we don't know the future risk, but till this moment we don't have. That doesn't guarantee that we will not have any bleeding in the future. That's why we are trying to figure out the destiny of those remodeling, so to say, remodeling area, I mean the neck region. But it is behaving differently than the coils do. With the coils, you have compaction, you have eccentric regrowth, and it regrows and regrows. So you need to retreat them for sure if there's a growing remnant at the base. With those, they stay the same at least till 2.5 years so far. So with those, if there's just a remodeling of the bifurcation, why not accept it if it does not change its shape and it is stable, not putting additional risk to the patient? I mean, our aim is not treating the picture, the best picture, but preventing the patient for a future bleeding? So we don't know the answer yet, of course, and these are not straightforward aneurysms. There are either, for example, ruptured white neck aneurysms, which can be treated with stent-assisted coiling, but then you need to give anti-aggregating drugs, but with lead you don't have to. Or they are very complex shaped bifurcation aneurysms that doing stent-assisted coiling will be more risky, at least in our understanding. That's the idea.
Yeah, but if you classify the aneurysms with a complete occlusion, partial occlusion, neck filling, remodeling, it means that they have different rebleeding risks, because otherwise there's no need for further treatment. And if they no rebleed, why to use a?
Well, we don't know the future. With that understanding, we cannot say anything till 20 years at least, because we have to see the future. But this is a proposal to expand the routine classification that we are using for coiling with 2 to 3 subdivision: complete occlusion, neck remnant, and aneurysm remnant that in Roy-Raymond classification. We need to expand it. That's what we are believing. We are not excluding other things.
This image is not maybe the configuration of the device, the inferior part of the device. Maybe this.
Exactly. It is possible.
It's not the aneurysm, it's the configuration of the device.
That's what we are saying, actually, because there's a barrier there. It does not end up in compaction, but it stays as it is, and it is preventing, hopefully, any future bleeding risk. That's what we think.
Okay.
What is the experience you are the modification after 6 months after the work of the intrasaccular material? Because with the Luna de last year, Charles Remunayer presented the modification of the device in evolution. So you have this experience in the intrasaccular device?
We don't have any experience with Luna. We only have experience with web device. And most of our experience with single layer, only very few double layer web devices. And if, in our experience, we did not have any device shape change in the follow-up in that week. And we believe that if the size is selected very meticulously, very cautiously with measurements, then it will be less of a problem. But if it is loose, because you are concerned about having a rupture or not, placing well, compromising the flow after bifurcation, you select a small one, and it is losing the aneurysm. It is very well possible that it may change its shape in the follow-up, even though at the beginning it may look okay. So our understanding is, if you select the size correctly, and it places securely in the aneurysm, then it does not change its shape.
So thank you very much. We have finished for the moment, so we go for lunch.